start the first talk of the section, Managing Rhegmatogenous Retinal Detachment by Dr. Dinesh Talwar sir, who is the Chief Vitreoretinal Consultant at Center for Sight, Delhi. Over to you, sir.
Good afternoon. Let's get straight to the topic because I think we're running out of time anyway. It's my disclaimer and my financial disclosure. To manage something, you have to know why it occurs. So why does first of all, what is a retinal detachment? Everyone knows that it's a separation of the inner 9 layers of the retina from the RPE. But the question is, why does it occur? It occurs because there's a potential space between the RPE and the other 9 layers, which occurs during development. When the optical vesicle invaginates, the RPE develops from the outer layer and the inner 9 layers develop by the invagination of the wall. So that's where you have this space coming from. Now what keeps this retina attached? Now this is important. If you want to know what detaches it, you have to know what attaches it. So the most important thing is anatomical factors. The retina and the RPE per se provide substantial resistance to water movement. Now imagine if a break occurs, water movement will go through. So detachment will occur. An intact vitreous plug. Now this is very important because we talk about role of scleral buckling. So basically scleral buckling is effective because there is a vitreous plug and that plugs the retinal hole when you put the buckle. And that prevents further occurrence of a retinal detachment. Metabolic factors. Do you realize that the RPE pump can pump fluid from the subretinal space at a rate which is approximately 300 microliters per hour or 5 microliters per minute? Compare it with aqueous outflow, 2 microliters per minute. So it's double the rate of aqueous outflow. So that means the moment you close the brake, the fluid will go away. Finally, the physical factors. This outward movement of fluid pushes the retina against the RPE, but it will only push it if there is an intact intact retina. If the retina is torn, the fluid will go under the retina. And this is a very small pressure difference, 0.5 into 10 to the power minus 3 millimeter mercury. Even this is enough. And finally, you have the interphotoreceptor matrix, which is a kind of a glue between the layers. And this causes the adhesion of the RPE to the photoreceptors and keeps them in position. Now, if you expose the subretinal space by a break, then the binding properties are lost. That area gets hydrated and loses its adhesive property and detachment occurs. This is also the basis for the link-off rules. Because where does the exposure occur? Towards the posterior vitreous base. Towards the anterior part of the posterior vitreous base. What will get exposed? The edge in between. That will get fluid. First, the retinal detachment has to go to the ora. That is why all rhegmatogenous detachments go first to the ora and then spread downwards. Now, basically, from this it's obvious that this tap has to be turned off. You turn the tap off and the retina will settle. There are enough reasons for it to settle on its own. So this is the crucial step for us. But then there's a whole football field inside. Where do I look for this hole? So now, fortunately, we've got old veterans who found that out, that in a superior detachment, which goes on the other side, crosses the 12 o'clock meridian, this is a triangle, 1 clock hour on either side at the equator, and at the apex at the ora, look for a break there. You have a superior nasal or temporal detachment, look in the superior quadrant within a clock hour. You have an inferior detachment, look on the side where the fluid is more. And when an inferior detachment is there, but if it's very bullous, your hole is above the horizontal meridian. So there are a lot of reasons for you to be able to pick up where that hole is. In addition to that hole, now the hole is there, you picked up the hole, but if there is proliferative vitreoretinopathy, then it will again prevent the retina from settling back. So what are the grades of that? You have the old classification was there, A, B, C, D. A was Schaper's sign, which is pigment in the vitreous. B was partial thickness folds. And the A and B do not really affect your prognosis. But what about C1 to C4? These are star folds on in various quadrants. If they are there, then if it's more than 1 or 2 star folds, you're going to have a problem with buckling. If it's more than that, or if it's D1 to D3, that means the entire retina is closed posteriorly, you can't see the disc, then again you won't be able to settle by a scleral buckling. The newer classification classifies it in terms of clock hours of involvement. You have circumferential traction when on the circumference at the posterior vitreous base, it's sort of swing up. So what will happen? Irregular radial folds will happen. It pulls into the center of the retina, perpendicular folds will happen. Or it folds anteriorly towards the ciliary body. And now you're going to get a trough and you're going to get a loop called the anterior loop traction. What will it do? It will shorten the retina in the anteroposterior direction. Important for you to diagnose because only then can you treat them. Now see this is perpendicular traction. I'm sorry, this is only a piece of cloth, but you can see if it's pulled into the center, it's perpendicular traction. If on the other hand, there is circumferential traction which is folding it together, what will it do? It will create this radial fold. And if it folds anteriorly, you get an anterior loop traction as you're seeing here towards the aura. And if it's only a focal area, it's a star fold. Now you need to know this so that you can decide how to manage your patients. And similarly, if it's posteriorly, if it's star folds which fold the retina back, they're again going to cause, or it could be focal or diffuse, or you could even have subretinal bands. Now it's easier to sometimes figure out what they look like, and this is just a small video to show you. You can see a subretinal band. So we put a little of PFCL, you see it's not settling back. That's the best way to diagnose it. If it's not settling back, you need to remove it. So this is a clothesline kind of a subretinal band. We take it out, make a small retinotomy, take it out, and pick it off with a forceps. And once this traction goes away, the retina will settle. Now, what are the basic principles? The important thing is retinal detachment surgery is almost mathematical. You can tell exactly what you have to do and manage it in that way. First of all, what is your objective? Temporary closure of the brake. You close the brake, I showed you, the SRF will go away. The RP pump will take it away. Now what do you want to do? If you don't create an adhesion between the RP and the inner layers, it will again open up. So you need to do laser or cryo. With laser, it's like a stapler. It immediately starts attaching within a few hours. The first 4 hours is not, it has no adhesion, but within 18 hours, adhesion starts. By 2 weeks, it's normal strength. With cryo, it takes longer for it to reach its adhesiveness, but within a few days, even that works. So this is what your next thing is. After that, what do you want to do? Now, you have to close that brake. How can you close the brake? One, you can close it by gas with pneumatic retinopexy. You can use the buckle, and the buckle uses the support anteriorly and the vitreous plug from inside. The buckle won't work in a completely vitrectomized eye with no vitreous and no tamponade. So you need the vitreous along with the buckle to do scleral buckling. And finally, if you remove all the vitreous, you remove all the traction, and you give support from inside with gas or silicone oil. And that is a vitreous surgery. Now you want to tackle your traction. So for circumferential traction, radial folds, how will you manage? If you want to do do a scleral buckling, you'll actually need to put a radial buckle. We don't do it nowadays. If you have a patient like that, go ahead and do a vitreous surgery. Remove that membrane. If you have perpendicular traction, here you can put an encircling band and it will bring the circumferential diameter will become, the circumference will become less and the retina will settle. Or do a central vitreous removal in a vitreous surgery. And finally, you have anterior loop traction. The only way to settle it is with a very high circumferential buckle and with scleral imbrication. You'll have to combine them to get adequate shortening. Easier way is go and do the vitreous removal meticulously and it will open up. And if you are impatient type, do a retinectomy. Now, what is the advantage of a conventional scleral buckling? It's primarily an extraocular procedure, no effect on the lens, no development of cataract. Disadvantages. Accidental perforation of globe, less likely now with the microscope use. Myopic shift will always happen. Buccal related, buccal infection can happen once in a while. If you allow pressure to go up too high, you can even get a CRO. Risks of SRF drainage are what scares you the most, and that is incarceration and subretinal hemorrhage. We'll come to that in the end. Now, what about the advantages and disadvantages of primary vitreous surgery? The best thing is it's controlled surgery. That's why all of us like it. Tackles the primary pathology, but also that the risk of subretinal hemorrhage is negligible, risk of incarceration is negligible, risk of distortion is negligible, and no buccal infections. The most important disadvantage is cataract formation. So how do you choose? If you want to do vitreoretinal surgery, how would you do it? Internal removal of traction. Encircling band you may want to give sometimes to support the vitreous base. You put C3F8 or silicone oil for tamponade, cryo or laser along, and you remove the silicone oil if it's been put. If you have an anterior break, buccal is preferable. Posterior break, vitreoretinal surgery. Few small breaks, buccal. Giant retinal tear, vitreoretinal surgery. Shallow RD, a buckling is good. Very bullous or very severe PVR, conditions where it will be more difficult to do a buckling, VR surgery. Assess the lens status. If the patient is pseudophakic or aphakic, VR surgery is easy. If it's phakic, if the peripheral break anterior to the equator, moderate height of RD, not much hypotony, and 3 and 9 o'clock or 9 o'clock meridians are involved by the RD. These are situations where a scleral buckling is the preferred mode of treatment. On the other hand, when in a phakic patient, would I still want to do a vitreoretinal surgery? Just if it's a posterior break, if it's a giant retinal tear, or if it's a very bullous RD, or if there is hypotony with associated choroidal detachment or severe PVR. Here, you go and do a VR surgery. Now, I'm not going to discuss this because I think I've already run out of time, but basically, you have to ensure when you do a buckling that your sutures are at least 5 millimeters posterior to the posterior edge of the break, and the distance between your buccal sutures is 1.5 times the size of your buccal. So for a 7 millimeter buccal, you put a 10 millimeter distance between the sutures. Now, the encircling band will reduce your perpendicular and circumferential traction, and it also makes the buccal relatively permanent, and this is basically put at the equator. But the important thing is that the tightening of the encircling band should never be more than 20% of the circumference, and that will answer in if you ask any questions on that. Drainage, the technique we use is called a modified needle drainage. We use a needle to just make a small hole, and 100% guarantee no incarceration will occur. I can tell you over the last few thousand cases, no incarceration. But the risk of subretinal hemorrhage is always there, so do a careful indirect ophthalmoscopy, pick up an avascular area and drain from there. We modified the sequence of buckling to do first pass the band and the buccal sutures, then place the band and the buccal in position, confirm they are adequately positioned, then do the SRF drainage and immediately tighten. So no hypotony, and this prevents any risk due to the hypotony. Then do the cryopexy. Now when you do the cryopexy, you're doing it in a dry retina, so there is no dispersion of RPE cells within the subretinal space. And then go ahead and tighten to the appropriate length. This is a little different from conventional technique, but a much safer way of doing the buckling procedure. Now, I've already discussed about how you modify if you have doing vitreoretinal surgery. The important thing is if you're using silicone oil into tamponade, you have to do a almost complete vitrectomy, shaving the vitreous at the vitreous base. If you don't do that, you're going to get more recurrences, more holes, and you may get hypotony. This is just to show you, this is a simple vitreoretinal surgery. We've done first you do the vitrectomy, go ahead and then after you've done the PVD and the posterior vitrectomy, then put the PFCL to stabilize the retina. You will see the anterior retina becomes absolutely stable for you to do a vitrectomy. It's not likely to come into the port after that. Complete your anterior vitrectomy, and after you've completed your anterior vitrectomy, go ahead and make the retinotomy, and then once you made the retinotomy, go ahead and do the SRF drainage. What you're seeing here is the retinotomy and the SRF drainage. I think I will let this go ahead. Okay, this is one last part to show within this. See, what happens is, if you see carefully at this site, you can detect when you've drained enough fluid. When you will see that as the fluid goes away, there's a point will come where the PFCL will suddenly disappear. That's the point when you know you've more or less done 90% of drainage. And that gives you a good guide to that you've drained completely, and now you can go ahead and complete your drainage. And then remove the PFCL. Now let's come to this. This will also show you the various grades of PVR. Look carefully. If you look carefully, you can see the posterior membrane is there covering the entire circumference, causing perpendicular traction. You see this membrane being removed, and then behind it you see these radial folds. You see the radial folds which need to be opened up at a later date. First we are removing this perpendicular traction at the vitreous base, and now I am using this spatula to separate out the membrane this is the D3 configuration, and look carefully. See this membrane? Looks as if these are inoperable cases. They are not. Actually, once you get the plane, they are very easily operable, so never give up on them. But be careful. If you create a break at this stage, you'll lose the eye. So the important thing is, we picked up this. Now you can go ahead and put PFCL, open it slowly. Don't put too much PFCL, just a drop. Open it a little bit. Use a diamond dusted to remove those creases. Open it further. See whether there are any membranes there. Remove those membranes. Keep on going further and further anteriorly till you've removed all of them. And this is what we are doing here. Slowly. I think there's only one slide after this. So I'm sorry. Look. So as you can see, you will again and again find membranes. You have to remove them all. You can't leave them. If you leave them even 20%, it will not settle. So you have to remove as many as possible. The diamond dusted scratcher is a very good instrument for that. Helps you to pick that up. The other important instrument is a spatula, a 25 gauge spatula by Alcon. That helps you to pick up the membranes. And you can, once you get that edge, you can use that to remove the membranes from there. And you can see it looks, now this looks as if it's done, but it's not. Actually, those radial folds which were there, they translate into membranes anteriorly. You have to remove all of those also. And you can see now I'm removing those. Can you see this vitreous over here? This is the vitreous which was now putting the circumferential folds, causing the radial effects on the posterior pole. So we remove those. Yeah, I'm just finishing. Yeah. Okay. I'm not going to go into this. Those who like, basically there are three bugbears of retinal detachment surgery. You have one which is subretinal hemorrhage. If you do a safe drainage, this will vanish. Retinal incarceration, again, will not occur with the technique we described. It vanishes. Cataract as a complication of VR surgery is always going to be there. So, ladies and gentlemen, if you do your surgery with thought process alive, seeing what is there, making your diagnosis of where the traction is, what the traction is, what is the safest way, you get overall reattachment rates of more than 90%. Remember, the worst cases are macula on cases. 6/6 vision, macula on. My worry is 10% of these patients are going to lose vision. They are not going to gain vision. So you must do proper counseling in these cases. The rest, you can expect to give more than 6/18 vision in more than 50% of your cases. Thank you, ladies and gentlemen, and sorry for the time.
Thank you very much, sir, for that detailed and elaborate talk on retinal detachment. It was wonderful to have you here with us.